Doing the neonatal oxygen checkoff. What I'm going to be following is the data arc sheet. Okay, what I'm looking for is for you to identify the steps and then to physically be able to put the equipment together. And if we're missing a piece of the equipment, like we do not have an O2 blender, say that you would hook it up to an O2 blender. Okay, make sure you identify or make me aware of that there's a piece of equipment that would be put in place if you were actually in the clinical setting. Like O2 analyzers, guarantee if you're in NICU, they'll have an O2 analyzer there for you to use. So the very first thing I would do is I take my data arc sheet, and if I was called to go to NICU intermediate to place a baby on a oxy hood, I would go ahead and find the baby's chart, and I would look for the order from the physician as to why, what I need to do, and why I need to put it on the baby. Okay. I'm going to look for significant findings. I want to make sure I have the right baby. I'm going to look for patient identification numbers like we've talked about before, any of the other checkoffs. We might have the identifiers. We want to find out any indications, and then we also want to find if there's anything that we need to be concerned about. Of course, with babies, especially low birth weight infants, we're worried about ROP, retinopathy of prematurity, or retrolental fibroplasia. And so we want to minimize the amount of oxygen because we'd like to keep the P-AO2 truthfully somewhere between 50 to 70, 50 to 80 millimeters of mercury. We don't want it greater than 80. Remember, the Academy of Pediatrics talks about keeping it less than that. So then after we've done that, we need to go ahead and gather our equipment. Gathering our equipment, right now, of course, this is not aseptic technique, but we need to get the oxy hood. We need corrugated tubing, enough lengths to go from our humidity or aerosol source from the blender to the oxy hood. We need an O2 analyzer with a T-bar that's working and calibrated, and we need sterile water for inhalation. If this is going to be set up in a controlled environment, a radiant warmer, an isolette, somewhere where the environment around the baby is going to be temperature controlled, that I'm not overly concerned about having the temperature of the gas using a heated humidifier. But if it's not, then I would want to think about using heated humidity for the baby. Okay. Next I'm going to do is, after I get all the equipment, of course this is saying I'm going to wash my hands, I'm going to knock on the door, I'm going to do through all the steps that we normally do. But when you're in NICU, it's a closed unit. You're not going to have nursing, you're not going to have the family members all in there. You're going to just do your job. But this is a good review. Okay, before touching the baby, you wash your hands. When you go to NICU or any of these closed units like that, you're not going to do a standard hand washing. You're going to actually go to the sink, and you're going to use the scrub brush. And you're going to break open this scrub packet, and you're going to be scrubbing your hands, your fingernails, making sure there's no dirt. You need to make sure you do that every time you come into the NICU. If you leave, you come back, you do it again. Okay? We don't want these little babies who are already very, very compromised with regards to being premature to get anything that we do when we travel around the hospital. After we've done that, it says introduce myself to the family, stating your name, department. Hi, my name is Alan. I'm from the respiratory care department. They've asked me to come up here and place little baby boy Blue on some oxygen, a 28% oxy hood. Okay. I've already checked the chart. I have the patient identification information, the number, medical record number, their date of birth, which is going to be newborn. Okay. The baby's not going to be able to talk to me. So now interacting with the nurse, the baby's primary care person, or if the family's there, with them. 9 out of 10 times it's going to be, you're going to be interacting with the nurse, the primary care nurse for that baby. At that point, you tell the nurse or the family member, we'll be putting on some oxygen to help your baby improve their oxygenation status. We want to make sure that they get plenty of oxygen. We don't really need to go through those other hazards like fire, things like that, because you know what? This is a controlled environment. Okay. At this point, if the family's there, if they have any questions, you're going to ask the family, do you have any questions? Okay. We're going to try to take the oxygen off the baby as quickly as possible. We just want to make sure that there's plenty of oxygen on board so that the baby doesn't have any kind of shortness of breath or any kind of deficits with regards to lack of oxygen in their blood. At this point, it says to do the patient assessment. And I'm going to look at heart rate, respiratory rate, sat color level of dyspnea. Of course, doing this patient assessment on a baby is going to be a little different they're going to be, if this is an ICU, they're on a monitor, okay? They're going to have ECG leads. They're already going to have a pulse oximeter on, and you're going to be able to do the full assessment of the baby. You can look at the monitor here in NICU, and you would do your assessment because you want to see how the baby was on room air. You're going to place the baby on oxygen and see if the baby improved post setup. Then the next thing it's going to be is you're going to set up your equipment. Okay, it says implementation of the procedure. And the implementation of procedure is that you're going to make sure that your oxygen blender is connected to your sources. With an oxygen blender, you're going to have to use two high pressure sources, air at 50 psi and oxygen at 50 psi. Both of those high pressure lines are going to plug into your blender. If both of those oxygen and air sources are not plugged into the blender is going to make an alarming sound. Okay, that's showing you that you don't have the two medical gases that are required at the proper pressure level. Okay, remember that the oxygen blender utilizes a proportional valve to use the air to oxygen ratio that we've talked about before. So if the baby was on 28% oxygen, that's a 10-to-1 oxygen ratio, air to oxygen ratio. So for every 1 part oxygen, I'm going to mix 10 equal parts of air to get the 28%. Then I'm going to confirm that FiO2 is actually there by using the O2 analyzer. And with your O2 analyzer, you would have done your 2-point calibration on this. Next, it says you're going to connect to a heated humidifier. Like I have said earlier, they're in a controlled environment. You don't have to worry so much, but if they're not in a controlled temperature environment, you definitely want to use a heated humidification source. And it's not what we normally see with the collar on our large volume nebulizers, like right there. It's not like that one there with the orange. Deb, can you hand that to us? Just the bottle would be good. So what we could use is we could use something like this, and we would put a heated collar around the side, and we would measure the temperature of the gas to make sure that we were not providing the baby with too cool of a gas. But what I've seen in NICU is they use a heated wire circuit, very similar to what you see on mechanical ventilators. Okay, and they use the Fisher-Paykel little automatic water feed that fills up, and it does a blow-by. Actually, it kind of goes over the top of the water. The gas goes over the top of the water that's been heated, and as the gas goes over the top of the water, it picks up heat and moisture to give to the baby. But if we were going to use this, we'd put a heater collar around the top and then measure the temperature of the gas closest to the patient, down proximal to their face. Next I'm going to do is I would connect the tubing from the humidifier to the oxy hood. So I'm going to use this one right now, and we're going to make believe like this is actually being hooked up to an oxygen blender. I'm dialing the oxygen blender to 28%. And at this point, I'm going to take my corrugated tubing, then I'm going to hook this up to my oxy hood. I'm going to set the temperature. My temperature probe will be down closest to the patient. There's a flexible metal plastic covered bar that would sit over the top of the hood to keep the hood down. Then I would also have my O2 analyzer. And there's two different trains of thought here, okay? What you're going to do is normally your baby will not have their head straight up. They'll be turned to one side or the other. Wherever the baby's head is, you're going to put the O2 analyzer closest to the baby's nose or mouth. Not right on top, but close, because the gases are going to be stratified. It's going to be levels of different types of gases, and we want to analyze what's closest to where the baby's breathing. Okay? Remember, oxygen is more dense than air. So now what I'm going to do is I have this set up. At this point it says, place the neonate under the oxy hood, evaluates fit, patient comfort. Baby looks comfortable, O2 analyzer's in line. I've got my oxygen on, I've got it set at 28%. I'm analyzing at 28% here. And at this point, I'm going to monitor the temperature of the gas. I'm going to have a temperature probe here, and I'm going to measure the gas temperature. Same thing that we were talking about before, 36.5 to 37.5. We want to keep in that same type of range. And then we're going to make any adjustments as necessary for the baby. Okay, if we need to go up on the FiO2, or maybe the baby's temperature changes and we're going to have to change our temperature of our gas, because this is where the baby will lose most of the heat, is from their head. Okay, so we might have to adjust it because we want to make sure the baby's core temperature stays stable. We would still, just like in our NRP or emergency delivery checkoff, we put a probe on the stomach, a temperature probe with the cover. They're probably in a radiant warmer or in a controlled environment, an isolette. We want to make sure it stays covered because we just want to know what the baby's temperature is, their body temperature. At that point, we would make sure that we had an O2 sat monitor. Typically, you're going to see it on the right hand. It can go on different places. For the most part, it's going to be on the right hand. I'm going to be monitoring all of my saturations, my heart rate, my respiratory rate. I'm going to be watching how this baby responds to the oxygen. At that point, I'm going to evaluate the patient's oxygen status again within 1 hour. Okay? Typically, you're going to go ahead and do an ABG, and you're going to get your initial ABG, and then you can monitor with other methods, because you're going to correlate the ABG values with your SAT monitor or with your TCOM, your transcutaneous O2 monitor, CO2 monitor. You want to make sure that those values are pretty close. Then you can use those other devices as a trending tool and a weaning tool if you need to adjust your FiO2s. It says you're going to monitor the patient's heart rate, respiratory rate, color, and signs of shortness of breath or labor breathing. Then I'm going to, at this point, everything is set up. I'm going to go to my sink. I'm going to wash my hands, and then I'm going to go to wherever the patient's chart is, and I'm going to chart what I've done. That's good.
Would you do a CBG at all, or just an ABG?
At this point, just an ABG. Remember the CBG, the capillary blood gas, is really not good for oxygenation. It's good for pH and CO2. Can you get some information from a CBG with regards to oxygenation? Yes, because if it's venous blood, you know that the normal PVO2 is going to be about 40 and a saturation of 75. And if I find out that my PVO2 is like 30, then that means I'm even dipping into my venous reserves for my oxygenation. It means the difference between the CaO2 and the CVO2 is even wider. And what did we say when we see that widening? It's a problem with what? The heart. Remember the CaO2 and CVO2, and if they're greater than 4 to 5 vols percent, what's in the middle?
The heart.
The heart. So it's a cardiac output problem.
Could you keep the hat on the baby while he's in there?
That'll be fine. You don't have to, but yes, that'll be good.
That's fine.
If you're using the temperature, if you're controlling the